Thank you very much for inviting me to give this talk. So I'll be talking about comparing the epidemiology and clinical representation of monkeypox in Nigeria and the global north. I have no conflict of interest regarding this presentation. So the monkeypox virus, as we know, is a double-stranded DNA virus that belongs to the orthopox virus genus, same as variola, vaccinia, and cowpox virus. The first case of monkeypox was reported in captive monkeys in 1958 in Denmark, based on animals that were exported from Singapore to Denmark. The first human case of monkeypox was reported in a 9-month-old male child in the Basankusu district in the Democratic Republic of Congo in 1970. Currently, we know that there are two distinct genetic clades of the monkeypox virus. Clade 1, which causes disease, mainly in the Central African countries, and clade 2, which is known to be associated with disease in West African countries, and also responsible for the current global outbreak in the global north. So let's just give an overview of the reemergence and exportation of human monkeypox in Nigeria, just to set a context to our discussion. The first case of human monkeypox in Nigeria was reported in 1971 in a 4-year-old unvaccinated female who subsequently transmitted the infection to her mother, who is a 24-year-old unvaccinated young lady. And they both lived in a rainforest area of Abia State. So this was the first documented case of human-to-human transmission of monkeypox. It took about 6 to 7 years for Nigeria to report a second case in a 35-year-old male who was a traditional herbalist and was also unvaccinated and became infected actually in Benin Republic and came to Nigeria where the infection was diagnosed. He had no distinct exposure, but said to occasionally consume bushmeat. Between 1971 and 1978, there was intensive search for human monkeypox in Nigeria, but no case was detected. There was a silent gap for about 36 to 38 years until around September 2017, when Nigeria reported a resurgence of human monkeypox. The first case was an 11-year-old male child who presented to my hospital in Bayelsa State, Nigeria. Actually, this child was not necessarily the first case because he actually acquired the infection from his uncle who was 35 years old. In the space of about 3 months in this year, 2017, 88 cases of human monkeypox were confirmed in 14 states and that is out of the 36 states and the Federal Capital Territory of the country. The next year, 2018, the number of cases declined to 49 and 17 states reported cases. And this was a time that Nigeria also started exporting cases to the global north. So in 2018, we had 2 exportations to the United Kingdom and 1 case was exported to Israel. Majority of cases occurred amongst males, about 60 to 70% of them were males and within the age bracket of 20 to 40 years. 2019, the case count also declined a little bit, which was 47 cases, and majority were males. We reported 1 death. And there was also exportation to United Kingdom and to Singapore. 2020, on account of the COVID-19 pandemic, only 5 states reported cases of human monkeypox. 73% of them were males. Of course, there was no exportation in 2020. In 2021, the case count was 34 cases, similar demographic pattern, no deaths were reported. But in 2021 was the first time cases were also exported to the United States of America and as well as the United Kingdom. Most of these cases of exportations occurred from the Delta region and some from Lagos, Nigeria. In 2022, as at 14th of August, Nigeria had reported 220 cases of human monkeypox in about 29 states. And this is the largest number of cases that have been reported so far in the country. In May 2022, 2022, we had exportation too of monkeypox to the UK. So far we've had 1042 suspected cases, 446 have been confirmed, 12 persons have died, giving a case fatality of 2.6%. Before this outbreak, 3 confirmed cases and no deaths. And this is just to give a global comparison in the differences in the viral clade between what is happening in Nigeria and the global north. This is a phylogenetic tree that gives us the cursory look of the genomic sequence of the viral strains that were isolated both from Nigeria. Just to emphasize here that this is a Nigerian strain, that the global strain is more divergent than the Nigerian strain, which shows that the virus is evolving. Further details is provided in this clock phylogram, which shows that over time from 2017 to 2022, there have been several single nucleotides polymorphism. About 5 substitutions per year have occurred. It shows that the virus has evolved over time. Some researchers have even looked at it closely, and they reported the ApoBec 3 mutations, which are peculiar to human beings, and had noted that it is possible that the virus had adapted to the human host with human-to-human transmission beginning in 2016. So the number of cases of monkeypox as at August 26, comparing Nigeria with the global north, you look at the cases here, you see that the regions of the America, European regions reporting over 20,000 cases, whereas Nigeria is reporting just about 220 cases. A number of factors could account for this. This just gives us a trend of cases that have been reported from 1971 to 2022 over time. So these differences in case count could be attributed to the fact that the outbreak in the global north has a super spreader or amplifying events that resulted in multiple infections, and that's why they have multiple cases. Secondly, it's also due to better levels of surveillance and testing compared to Africa, specifically Nigeria. It is my view that the case count in Nigeria is grossly underestimated because of some of these challenges in the health system, poor health-seeking behavior, issues of surveillance, and issues of testing. So let's compare the demographics of the Nigerian outbreak and that is occurring in the global north. In terms of gender, you could see that Nigerian outbreak, roughly 60 to 70% of cases are males, and the majority of the cases, close to 95% of the cases in the global north, are males because it predominantly affects gay and bisexual men. In terms of age group, roughly over 50% of the cases in Nigeria are between the ages of 20 to 40 years, whereas majority of the cases in the global north are within the ages of 20 to 40 years. That is more than 80% of the cases. Of course, Nigeria has also equally reported cases in those less than 10 years and above 50 years. This is just to give an overview of monkeypox occurring in cities and other settings. In the Nigerian outbreak, currently monkeypox has spread beyond the typical rainforest areas, so we're reporting it across cities across the country. In the 2022 outbreak, remarkably, Lagos, which is the biggest city in Nigeria, has reported the largest number of cases. 35 cases were reported in Lagos alone. But we've also reported cases in closed settings. In 2017, there was a prison outbreak, and in 2022, there is another prison outbreak in the northern part of the country. And this tells us that monkeypox is circulating more or less within cities, urban settings, and also a few closed settings in Nigeria. The same, this also gives us an overview of the occupational group of cases that are affected in Nigeria, showing diverse occupational group, and also telling us that most of those people that are infected are not necessarily hunters or farmers that live in a rural setting. In the global north is a similar picture. Big cities have reported more cases than the smaller cities. New York, California, and London in the United Kingdom have reported more cases. This just tells us that monkeypox has emerged to be a problem of cities and urban settlements, both in Nigeria and the global north. In terms of modes of transmission of monkeypox, for the Nigerian outbreak, based on the data available from the 2017 to 2019 outbreak, majority of cases had unknown source or mode of transmission of the monkeypox. 30% reported contact with a close contact with a suspected case. Some of these contacts are intimate contacts or household contacts. 8% reported some form of animal contact, including contact with domestic animals. For the global north, majority of the contacts were sexual encounters, and we had other modes of transmission, including contaminated materials. There are also other risk factors that were observed in the global north and have not been well characterized in the Nigerian population. For instance, gay and bisexual men are the most affected group. We don't know about that in Nigeria. STI is featured prominently. HIV and issues of multiple sexual partners are featured prominently in the global north. So, is there any role of sexual behavior in the transmission of monkeypox in Nigeria? This was something we looked at in our cohort in Bayelsa State, my hospital. And the first publication we had on monkeypox was in 2017, the PLOS ONE journal. We just gave the impression that on account of the fact that the majority of our cases were young men that had genital ulcers, we suspected the role of sexual transmission, either through skin-to-skin contact or via genital secretions. More recently, we published a study in the International Journal of STD and AIDS, which showed that some of these patients had history of high-risk sexual behavior, multiple sexual partners, condomless casual sex, transactional sex, and sex with someone with a skin rash. And in 2022, our preprint has shown proposed a possible role of heterosexual transmission of monkeypox via casual sex partners in Nigeria. But these findings were restricted to a single center, and there is need for more elaborate studies to define the role of sexual transmission of monkeypox in Nigeria. In terms of clinical presentation, majority of the cases in Nigeria present typically with the febrile prodrome and rash, then other clinical manifestations. The rash predominantly occurs in the face, the limbs, the trunk, but 66% of cases develop rash in the genitalia. The rash, in this case, there are some patients that did not even develop rash in the global north, and they had variable presentation. Fewer patients had fever, and some of these patients did not have the typical viral prodrome in the global north. And what is also typical here, majority of the rash occurred in the genital area, as opposed to the Nigerian outbreak where majority occurred in the face, on the face. And there are different types of lesion. It was also commonly reported, a single rash was reported in the global north. In Nigeria, we reported just one case that had a single rash. Clinical presentation also gives details of the number of lesions. From the description of 40 cases in Nigeria, we noticed that majority of patients had lesions above 100, as opposed to the global north, where most of the patients had lesions less than 20. But just to remark that in the current Nigerian outbreak, based on a study from our cohort in Bayelsa, 7 of our cases all had lesions less than 100. In fact, a few of them had lesions less than 20 lesions, and most of those lesions were concentrated on the genitalia. Mucosal lesions were also reported in Nigeria, including sore throat, oral ulcers, genital ulcers, nasal ulcers, and several complications were reported, but only a few patients were evaluated for these complications. Remarkably, Nigeria reported anxiety, depression, and even a case of suicide in a young man that had monkeypox. And variable presentations have also been reported in the global north. And what has not been seen in Nigeria is especially acute kidney injury, myocarditis, and anorectal pain or anorectal discharge has not been reported yet from the Nigerian population based on published literature. It was a relationship between monkeypox and HIV. In the Nigerian outbreak, about 90-something persons were tested. Out of this number, 28 were HIV positive. Viral loads are not necessarily very valuable. Most of these patients were not receiving antiretroviral therapy. The case fatality in that cohort was about 20.8%, and all the cases had, a few of the cases that had CD4 count less than 360. Some even had CD4 count less than 100. And what that study, a recent preprint, showed was that monkeypox was 41 times more likely to, monkeypox cases were 41 times more likely to have HIV infection. Monkeypox HIV co-infected persons were more likely to have severe disease and also more likely to die. In the global north, about 41% of cases had HIV co-infection. Viral loads and CD4 count were high, showing that they had good response to antiretroviral therapy, and most of them were receiving antiretroviral drugs. Of course, no persons have died so far. There was no significant difference in the clinical presentation between those that are HIV infected and not HIV infected. However, there are a few case reports of severe epiglottitis in an HIV infected patient and a disseminated disease in a newly diagnosed HIV infected patient. This just gives a clinical picture of some of the cases seen in Nigeria and the global north. These are female cases here having different types of genital lesions. These are male patients with scrotal swelling and penile edema and the likes, and different types of lesions. This is an hemorrhagic lesion, and these are gluteal region lesions on a female and single lesions on the limb. Similar lesions have been reported in the global north. This is a single lesion reported in the global north. This erythematous rash, macular rash, to the best of my knowledge, has not been reported in the Nigerian outbreak. So what are the clinical outcomes when you compare the two groups? For Nigeria, based on the data from the Nigerian Center for Disease Control, out of 446 cases, 12 have died, giving a case fatality of 2.6%. For the global north, 6 persons have died. So the cases that have died in Nigeria, those majority have HIV infection, some had sepsis, neonatal encephalitis, renal failure. Information for the others are not available at the time of this presentation. For the global north, we have Spain, Brazil, Ecuador, Cuba, and recently United States of America reporting a deaths, and the reasons for these deaths are stated clearly here. So what of therapeutics and vaccines? Nigeria has no therapeutics specific for monkeypox and vaccines to the best of my knowledge. And if you look at the global north, majority of the countries, most of the countries have access to vaccines. Just to give you two examples of the UK and the United States of America, how much vaccines have been distributed, and even therapeutics have been distributed to these countries, but Nigeria has none. So this chart is just to remind us about our level of interconnectedness as a global village and the need for global solidarity. Monkeypox was largely a neglected disease that was restricted to Central and West Africa. But in 2022, we are now reporting cases in Europe, in America, and across the globe. That tells you that infectious diseases have capacities to spread globally and affect all countries. And this tells us that we are all interconnected and interrelated. And this is an important time for us to understand that we must rethink the concept of national interest regarding exposures and response to infectious pathogens, because your borders are not distinct when it comes to infectious pathogens. And on that account, we should ensure that there's equity in the distribution of medical countermeasures for all countries, including the countries where monkeypox emerged from, which is Africa. And up to date, Africa does not have any of these medical countermeasures. There's need for more investment. Ensure that we understand monkeypox better, and we're able to address this challenge of monkeypox. These are my references. Thank you very much for listening.